member from Rajasthan for Central IIP. He is director of the City Hospital at Jaipur, and he is former founder secretary of Adolescent Health Academy chapter of Jaipur, and he was former secretary of IIP Jaipur also. Presently, he is North Zone coordinator of the pediatric gut GPT module. We welcome Dr. SP Sethi sir and request him to introduce the speaker and say a few words.
Thank you, Dr. Ajay Kumar Gupta, for such a nice introduction. Good morning, everyone. It's a pleasure to welcome you all for today's session of the Master E-Class in Pediatric Rheumatology, organized by Indian Academy of Pediatrics, Delhi branch. We are fortunate to have with us Dr. AVINASH Sharma, and a little bit introduction of Dr. AVINASH has done his DM from Pediatric Clinical Immunology and Rheumatology from PGI Chandigarh, India. Currently, he is working as Associate Professor in Specialty Cell of Pediatric Clinical Immunology and Rheumatology Department of Pediatrics at Rajendra Prasad Government Medical College, Kangra, Himachal Pradesh. He has more than 30 publications in national and international journals to his credit. His area of interest are clinical aspects of Kawasaki disease. I look forward to an insightful and practical session that will enhance our understanding and help us to manage such cases better in our clinics. I am last but not the least, I am also thankful to Dr. Ajay Kumar Gupta, who is coordinating this, Delhi IIP President Dr. Pankaj Garg, Dr. Shyam Meena, Dr. Ankur Jindal, and many more. Thank you. With that, I invite Dr. Avinash Sharma to please take over.
Thank you so much, sir.
We also welcome our faculties, Dr. Ankur Jindal and Dr. Pradeep Patra. Sir, please go ahead.
Yeah. So once again, I would like to thank Delhi IAP, Dr. Ajay, Dr. Shyam, Dr. Pankaj, Dr. Anu Maheshwari, and I would also like to thank the chairpersons for this nice introduction. So this has been, I believe this has been a very successful program where difficult topics like all the rheumatological topics have been discussed. I would also like to thank the previous speakers who have been dealing with these difficult topics throughout these weeks. I can see Dr. Pratap Patra and Dr. Ankur Jindal, dear friends, and they have made the task a bit easier now that we all have a little sensitization about these difficult topics which have been discussed in the previous sessions. So as Dr. Ajay was discussing, can I share the screen now?
Sure, sir.
Okay. So as Dr. Ajay was saying, this is a topic which is conditions which are not commonly seen, extremely rare conditions. But I would say that one must be aware of such conditions, these conditions, so that these are included in our list of differential diagnosis whenever we encounter these patients in the correct context. Meaning that if we get a patient who has these signs or symptoms which suggest these autoinflammatory syndromes, they must be included in our list of differential diagnosis. So I'm sure today's session will sensitize a bit about these not so common disorders. The previous session that I was involved in was dermatomyositis. So again, a not so common condition. So again, I'll be discussing a condition which is not very common. When we go through the pediatric textbooks, standard pediatric textbooks, we come across terms like periodic fever syndromes or autoinflammatory syndromes. So they are used in, synonymously, conditions like periodic fever syndromes or hereditary autoinflammatory syndromes, systemic autoinflammatory syndromes. What are these? What are the situations where we suspect these conditions, and how do we proceed whenever we suspect these conditions? I would also say that this is a very broad term. Too many conditions are included in autoinflammatory syndromes. So with the help of some cases, I'll try to highlight the fact that when do we suspect these conditions? And because the spectrum is very broad, so I believe today's session will maybe a bit longer. I've tried to include as many cases as possible to bring out the spectrum of these autoinflammatory syndromes. I would also say that I'm thankful to all the contributors who have contributed these cases. Not all cases have been seen by me. And I believe that people with more experience, more expertise in autoinflammatory syndromes are there in the panelists groups who have more experience, more expertise than I have. The common manifestations where we suspect autoinflammatory syndromes, I would say, are maybe presence of fever, which can be recurrent or persistent. So if we have a child who continues to have fever or has fever which recurs in certain intervals, that may be one of the situations where we can suspect autoinflammatory syndromes. Then there are different types of rash, which are also seen in autoinflammatory syndromes, as we'll see in the presentations ahead. Sterile lesions, a very important manifestation. What do these mean? Suppose we come across a child who in whom we are suspecting osteomyelitis, but the osteomyelitis is not infective. So this is a sterile lesion of the bone. So if we have sterile lesions, then this may also be a situation where we can think of autoinflammatory syndromes. And then there are manifestations like arthritis, joint pains, joint swellings, which can also make us think about autoinflammatory syndromes. So now coming on to the case, let's discuss this case. A young boy, a 9-year-old boy, comes to us with recurrent episodes of fever, which were there for last 2 years, some kind of rash, along with pain abdomen, body aches, joint pains, muscle pains. So the fever that this child had used to recur every 1.5 to 2 months. So every 1.5 to 2 months, the child used to have high-grade fever, which used to last for 7 to 10 days. So if a child has recurrent episodes of fever with a certain periodicity, will actually be given antimicrobials wherever they go. So any episode of fever virtually for us may mean infection. So in every episode of fever, he was being given antimicrobials. Interestingly, he used to remain well in between. Though this child is having fever now for last 2 years, but is thriving well and is absolutely fine in between, except those periods of fever that he has every 1.5 to 2 months. The rash that he had looks something like this. It used to occur with fever and occurs at different places, sometimes over the limb, sometimes over trunk, and migrates from one place to another. These episodes of fever and rash are associated with pain abdomen, sometimes myalgias and joint pains. So this is the history that the parents gave. There was no significant family history. Often such conditions, people with such conditions come with investigations that they carry usually in suitcases, a bundle of investigations they carry. So the simplest of investigations that we carried out were hemogram, which revealed a bit of anemia, elevated total leukocyte count, which was neutrophilic predominant, platelets elevated, ESR elevated. So I would say this hemogram is reflecting some kind of inflammation. Investigations that he had already had were investigations which were done to exclude infections. Yes, naturally and correctly, all kinds of infections were ruled out, including HIV, very some atypical infections like Borrelia or, all the kinds of infections he was evaluated for. Imaging, including CT scan of chest and abdomen, had been done, which were unremarkable. He had been evaluated for autoimmunity. ANA was negative, bone marrow was normal. So it has been tried to rule out infections, autoimmune conditions, malignancies, but nothing was remarkable. He had received antimicrobials, as already stated. He has had some hospitalizations and had received intravenous antimicrobials as well. As we can very often see in our setup, it is not unusual that a patient has received anti-tubercular therapy because he was having recurrent fevers. So he had been administered anti-tubercular therapy also once. And now, for past few months, the child was on alternate medication. But now that he had again an episode of fever, he reported to us, and we found these key points. So this young boy, a 9-year-old boy, is having recurrent fever. We can also say periodic fever, along with the rash, along with pain abdomen, some myalgias and arthralgias, arthritis. On hemogram, there is some suggestion of inflammation, and investigations are not suggestive of infections, autoimmunity, or malignancy. So this may be the ideal situation where one can consider autoinflammatory syndromes. So whenever a child comes to us with unexplained recurrent fever, that may be a situation where we suspect autoinflammatory syndromes, and the investigation that often helps is the genetic testing which we got in this patient, and we found that he had a mutation in the TNF receptor gene, TNF1 receptor, and we concluded the diagnosis as TRAPS, which is tumor necrosis factor receptor associated periodic fever syndromes. He was started on some kind of treatment and is showing some response to the treatment. So this was a classical case of autoinflammatory syndrome, which is TRAPS. So autoinflammatory syndromes can be defined as, the definition may not be very clear, but they can be defined as congenital disorders of dysregulation of innate immunity, which are characterized by recurrent or persistent inflammation without a primary pathological role of adaptive immunity. So we have been listening about rheumatological disorders. Most of them are autoimmune disorders. Autoimmune disorders are disorders of adaptive immunity, whereas autoinflammatory syndromes are disorders of innate immunity. They may not be very distinct, but predominantly innate immunity is affected in autoinflammatory syndromes. And that is why they usually present with recurrent or persistent fever because of inflammation, raised inflammatory markers, and often they do not have autoantibodies. Presence of autoantibodies suggest a defect in the adaptive immunity. So autoinflammatory syndromes are defects of innate immunity. We know that most of these cases are reported from countries like Turkey, where familial Mediterranean fever is so common that it is in fact the most common autoinflammatory disorder in the world. Whereas we know that we hardly ever see a patient of familial Mediterranean fever. So most of these autoinflammatory syndromes are reported from countries like Turkey, but I believe that India now being the most populous country, there should be no reason as to why we should not have a significant number of these conditions. But I'm sure a majority of us would not have seen a patient of autoinflammatory syndrome. And that may be because we have other priorities like infection. So whenever a child comes with fever, even if it is recurrent, even if it is persistent, we think of infections as the cause for that fever and lack of awareness. So sessions like this may help increase the awareness. And once we know that these conditions exist and how these conditions present, we will be more empowered to diagnose such conditions. Moving on to the next case. So we saw a case who was having recurrent episodes of fever along with rash, pain, abdomen, arthritis. Now this is a young girl, 3 years old girl, presents with swelling around wrists and knees, virtually from latter part of infancy. So at the age of around 8 to 9 months, she started having swellings around wrists and knees, and a rash was noted by the parents, which they said it feels like sandpaper. So it means it must be a very fine kind of rash, micropapular rash. And these were the complaints that the parents gave. A rash and swelling around the wrists and knees without much pain. In the family history, the father is also having these joint abnormalities, deformities of the joints, along with swelling of the joints, and some ocular complaints. So father was on follow-up in the ophthalmology department and is being treated for some ocular condition on a regular basis. On examination, we found that these were the swellings which can best be described as periarticular swellings. So they may not be called typically as joint swellings, but these look like periarticular swellings. So these were the swellings which the patient had. And along with this, she had short stature. And when an ophthalmological examination was performed, it revealed a granulomatous uveitis. So essentially, this looked like an autoinflammatory syndrome. So we went ahead with a focused genetic testing, which revealed a mutation in the NOD2 gene, which is diagnostic of Blau syndrome. So what is Blau syndrome? We can see that this patient did not have fever. So Blau syndrome patients usually present very young, and they present with a triad of rash, arthritis, and typically periarticular boggy swellings, like we saw, and uveitis. So presence of these three will make the clinical diagnosis very easy, and especially in the presence of the family history. Blau syndrome and many of these autoinflammatory syndromes are autosomal dominant in inheritance. So we are likely to find one or the other parents to be affected with these conditions. So Blau syndrome is sometimes also referred to as a type of young onset sarcoidosis, which actually it may not be. But because of the presence of granulomatous inflammation, because of arthritis, uveitis, sometimes it is considered as a young onset sarcoidosis, whereas pulmonary manifestations are not seen, and it typically does not behave as sarcoidosis does. So with this case, we learned that autoinflammatory syndromes like Blau can present just like juvenile idiopathic arthritis does. Now we have had more than one discussion on juvenile idiopathic arthritis. We know that these children, juvenile idiopathic arthritis children present with arthritis can have rash. Uveitis is a very prominent manifestation. So the autoinflammatory syndromes can present just like juvenile idiopathic arthritis does. So we discussed TRAPS. If you recall, we discussed Blau syndrome. People have tried to classify autoinflammatory syndromes, which is not easy at all. It may be a very complicated kind of classification if we try to classify them into inflammasome defects, non-inflammasome defects, interferonopathies, and many more. So what I've done is these can be divided into categories like this as well. So if we try carefully, autoinflammatory syndromes can be divided into groups, into those which manifest predominantly with fever. Then there may be a group which has predominantly sterile skin or bone lesions. There is a group which presents predominantly with CNS manifestations, and some autoinflammatory syndromes can also present like vasculitis. So if we try to divide into these classes, it may be easier for us to identify this. Moving on to the next case, after discussion of two cases, TRAPS and Blau. This is a young boy, virtually an infant, and is symptomatic since birth. A very important point to note that this child is having fever episodes since birth, along with an erythematous rash, which is also there since birth. And the patients and the family is moving from one place to another, looking for or finding out the reasons for this fever. Naturally, when the newborn has fever, he is evaluated for all kinds of infections, neonatal sepsis, and whatnot. So this young baby is having fever since birth, rash, but now he presented to the Department of Rheumatology because he started having progressively increasing swelling of knees. So what we found when we saw this, that along with the history and a list of investigations that he carried, what was interesting was that he carried an X-ray along with the enlarged knees. This X-ray looked somewhat bizarre. So there is a bizarre, it cannot be described. So there is a bizarre enlargement of knees on X-ray, proliferation of knees on X-rays. Along with this, the child had sensory neural hearing loss and a rash. Onset in the neonatal period with fever, rash, X-ray which looks like this, along with some neurological manifestations, makes the diagnosis very easy. And again, a focused genetic testing was done, which revealed a mutation in NLRP3 gene. And the diagnosis was, as the name suggests, neonatal onset multisystem inflammatory disorder. So this is an autoinflammatory syndrome, autoinflammatory disorder, which presents right at birth, neonatal onset. And this belongs to, the child was started on treatment, corticosteroids and some other kinds of treatment. This may not be the ideal treatment that this child should receive. In fact, interleukin-1 blockade or anakinra is the treatment of choice. which is though now available in India, but it is difficult to procure, expensive, difficult to administer, and it has been planned that this child will be shifted to anakinra if he does not respond to the treatment that he's getting. So this NLRP3 gene disorder or NOMID belongs to a group of disorders, autoinflammatory disorders, which are known as cryopyrin-associated periodic fever syndromes. Cryopyrin, cold-associated fever syndromes. So cryopyrin-associated periodic fever syndromes, there are some things in common in this group. They all result because of mutation in this gene NLRP3, and it is again a spectrum in which NOMID, what we saw, is the most severe form. NOMID may be most severe form of cryopyrin-associated periodic fever syndromes, the others being familial cold autoinflammatory syndrome, Muckle-Wells, and the result because of activation of inflammasome. Now, inflammasome has a role in our body that when it is triggered, it results in the production of interleukin 1 beta through caspase 1. So the final result is interleukin 1 beta. Interleukin 1 is a pro-inflammatory cytokine, so it will result in inflammation. In some autoinflammatory syndromes or in inflammasome-related autoinflammatory syndromes, what happens is there is either a low threshold for inflammasome to be activated, so it gets activated with very minor triggers, or it is persistently activated. So whenever it is activated, it will result in the production of interleukin 1, will result in inflammation. So conditions like NOMID, it is persistently activated because of a defect, mutation in the NLRP3 gene, and therefore there is persistent inflammation. And the treatment will be blockage of interleukin 1 with anakinra. So this was about cryopyrin-associated or inflammasome-related autoinflammatory syndromes, which can present with fever, rash, joint symptoms, CNS manifestations. In NOMID specifically, the onset is at a very early age. So we have come across now few autoinflammatory syndromes, one that presents with fever, TRAPS, then BLAU only with joint symptoms, then NOMID present in neonatal age. Now this is a 3-year-old girl presents with stroke, sudden onset hemiparesis. When asked for the past history, she was hospitalized at the age of 2.5 years, that is 6 months back, with pneumonia. And on examination, she has hypertension and a rash which can best be described as livedoid rash over her limbs. So a young patient with hypertension, a livedoid rash, and stroke, a possibility of vasculitis was considered. Correctly, a possibility of vasculitis was considered in this child. Now, though we'll be having sessions on vasculitis later, but I'm sure all of us know that the common types of vasculitis that we encounter in children are mainly two: IgA vasculitis, also known as HSP, and Kawasaki disease. We do not expect these manifestations to be there in either HSP or Kawasaki disease, but this looks like some vasculitis. So we went ahead with the genetic focused genetic testing because of stroke and clinical possibility of vasculitis. We did a genetic testing and found a mutation in the ADA2. And the diagnosis is deficiency of adenosine deaminase 2 or DADA2 or deficiency of ADA2. I must say that DADA2 is increasingly being recognized. This may be one of the autoinflammatory syndromes which is very frequently being diagnosed even in India, even in our setups, because it has varied manifestations, many phases. There are many situations where you can suspect deficiency of ADA2, and if worked up or examined correctly, then we may be able to find more and more cases of deficiency of ADA2. This patient was started on glucocorticoids along with infliximab and is showing some improvement. So we saw that DADA2 can present with vascular manifestations like stroke, rash, vasculitis-like manifestations. And in fact, it was considered as a cause of childhood polyarthritis nodosa or childhood PAN. So what people are now doing is whatever cases of PAN that they have, in all, they are doing the genetic testing. And interestingly, many of them are being now found to have this deficiency of ADA2 or DADA2 mutation. So it is an important cause of vasculitis, PAN-like vasculitis in childhood. Initial description of DADA2 was in children who had recurrent strokes. So again, interestingly, if we encounter pediatric stroke, especially recurrent stroke, DADA2 may be one of the first possibilities. The other manifestations are hematological. So if a child has unexplained cytopenias, it may again be a situation where we can think of DADA2. Many of them have hypogammaglobulinemia as well. So a patient with immune deficiency, recurrent infections, that may be the only manifestation of DADA2. So if a combination of recurrent infections, stroke, some cytopenias we see, then probably DADA2 is the thing to be looked at. So interesting autoinflammatory disorder, I would say relatively common in our place as compared to the others that we have discussed. Moving on to the next case, who is a young boy, 2.5 years old boy, comes to us. Now, this is an autoinflammatory syndrome who we have seen in our setup a quite number of them. This is a 2.5-year-old boy who comes to us with fever, which occurs every 3 weeks, lasts for about 2 to 3 days, and this is there for last 1 year. So again, virtually in infancy, after infancy, he started having these fever episodes, which occur every 3 weeks, last for 2 to 3 days. Along with these fever episodes, he often gets sore throat. And that is why he is almost always given antimicrobials. So I'm sure you can recall patients who come with recurrent sore throats. Almost every month they have an episode of sore throat along with fever. And this patient sometimes gets oral ulcers and is being given antimicrobials almost every time. And there is no significant family history. No other member of the family is affected with such complaints. This is the fever diary that the parents brought. So you can see, if you look at it carefully, you will find that almost every month, this child is having fever episodes, which last for about 3 days and recur every 3 to 4 weeks. At this time, he presented to us in April 2024. The frequency persisted. He continues to have fever episodes almost every month, but the duration of fever has decreased with whatever we have done. And the story still continues. The patient still continues to have fever. If you have this kind of fever diary, along with those symptoms, what I have described, this is a clinical diagnosis. He has been investigated at various places with hemogram, CRP, X-rays, throat swab, FNAC lymph node to reveal nothing. All of this has been unremarkable. So this is a clinical diagnosis, and the diagnosis is, the name is just a combination of symptoms. The name is PFAPA, periodic fever, aphthe, pharyngitis, adenopathy. So these children come with periodic fever, oral ulcers, pharyngitis, and lymphadenopathy. So this may be, if you think seriously, this may be a very common situation. You may find children who come with recurrent episodes of fever along with oral ulcers, pharyngitis, and lymphadenopathy. So this may be a patient of PFAPA, was started on oral glucocorticoids, which may not be the only treatment option. There are others as well whenever required. So in these patients, we do not give long-term corticosteroids. The other treatment options are, some people suggest tonsillectomy and a single dose of corticosteroid, dexamethasone or prednisolone, single dose of corticosteroid whenever they have fever. It is also said, it has also been seen that if we start them on glucocorticoids, the frequency in fact tends to increase, but the duration decreases. The important or reassuring thing is many of these children grow out of their disorder and the symptoms subside as they grow older. And interestingly, not all patients of PFAPA have a genetic defect. Now, with many people working on this condition, Many genetic mutations have been described to cause this syndrome, but there is no single gene defect which is responsible for PFAPA. So you may not find a genetic mutation, and this remains a clinical diagnosis. Very interestingly, many children of PFAPA have a clock-like periodicity. The family often knows when the child would have fever again, and they plan their holidays, vacations, or functions in such a way that to accommodate for that fever period. So PFAPA is said to have a clock-like periodicity. We have had many cases of autoinflammatory syndrome still now. So let us recap just to remind us whatever we have discussed till now. TRAPS, which presented with fever, rash, pain abdomen, joint pains. Blau, who did not have fever but periarticular boggy swellings along with granulomatous uveitis and rash. NOMID, neonatal onset, cryopyrin associated, inflammasome, NLRP3, started in the neonatal period with fever and rash. Deficiency of ADA2, cause of vasculitis, recurrent stroke, can have hypogammaglobulinemia and cytopenias. And lastly, we discussed PFAPA, which is a common situation we can encounter in our setups. Moving ahead. Again, a young girl, 6 weeks, 1.5 months old girl, presented with history of paucity of movements of both legs, which the parents noted 1 week back, along with swelling of left knee and swelling of right wrist. So someone thought of some osteomyelitis, and the patient was sent to us. So this is a young girl presenting with swelling of left knee and swelling of right wrist. However, there was no history of fever, lethargy, poor feeding, rash. The only complaint was that the child was not moving her lower limbs as the parents would have liked. On investigations, again, she was found to have elevated total leukocyte count, predominantly neutrophils, with elevated platelets, more than 8 lakhs, and elevated CRP, again suggestive of some inflammation. When X-rays were done, if you look at it carefully, it revealed lytic lesions in different bones. And these lytic lesions were reported by the radiologist as being suggestive of osteomyelitis. However, this child was not sick. There was no fever, and cultures from different sites, the blood culture, and when these sites were aspirated, the cultures were sterile. So we can say that these are sterile bone lesions. As we discussed in the beginning, autoinflammatory syndromes can also present with sterile skin or bone lesions. So this may be described as sterile bone lesions. When we did a genetic testing, it revealed a mutation in the interleukin-1 receptor gene. We discussed interleukin-1 related autoinflammatory syndrome, NOMID. This is mutation in the interleukin-1 receptor gene, and the condition is called as DIRA, or deficiency of interleukin-1 receptor antagonist. Again, the treatment will be interleukin-1 blockade or anakinra. The child was started on corticosteroids and planned for anakinra. This is an interesting situation where, and when do we suspect it? When we have a young child who presents to us with bony lesions, and many times they are symmetric bony lesions, as we saw in this case as well. Both the upper ends of femur had lytic lesions. So symmetric lytic bony lesions, you can think of condition like deficiency of interleukin-1 receptor antagonist or DIRA. So we learned from this case that osteomyelitis can be non-infectious osteomyelitis, and non-infectious osteomyelitis is a very important group of autoinflammatory syndromes. So I will say that even our orthopedic friends must be aware of this condition, that not all osteomyelitis is infectious and may not need treatment for infective osteomyelitis. The point which is highlighted in this case, which is probably the last case that I'm going to discuss. So this is a little grown-up girl, an 8-year-old girl, an age where we typically see many kinds of juvenile idiopathic arthritis as well. She presented to us with history of pain in right knee and left wrist, along with swelling. So asymmetric involvement, right knee, left wrist, which is there for about 1 to 2 weeks. There is no history of fever, rash, no other complaint. She was evaluated for uveitis as well. So nothing to suggest these kinds of things. So this is the only complaint that she had. Interestingly, in the past, she had swelling and pain of left ankle 6 months back, which was diagnosed by orthopedic surgeons as osteomyelitis, was treated for osteomyelitis, and was in fact operated and a debridement was performed. When now, because she had involvement of other joints, she was sent to rheumatologists, and when we investigated, we found that she had a little bit of anemia with normal TLC, normal platelets, normal ESR, a slightly elevated CRP. They're not much to suggest anything. When an MRI was performed, MRI was also performed when she had that ankle issue. So when we performed this MRI this time, it revealed inflammatory changes around her knees and even the elbows. And these were also suggestive of osteomyelitis. But this osteomyelitis is involving many parts of the body. So this is also a name which suggests the symptoms only. So this condition may be called as chronic recurrent multifocal osteomyelitis. So this is a condition CRMO, which is chronic recurrent multifocal osteomyelitis. Like the condition we saw PFAPA, which is again a combination of symptoms where you do not have the genetic mutation in most of the cases. CRMO again is a condition where we may not find the genetic abnormality or genetic mutation in many of them. Again, people are looking at this, and some genetic mutations have been described to cause CRMO-like conditions, but not many of them you will find genetic mutations. So this is again a clinical diagnosis, chronic recurrent multifocal osteomyelitis. This child was started on NSAIDs, to which she responded very well, and she has been planned for bisphosphonates as well. Chronic recurrent multifocal osteomyelitis, as the name suggests, is chronic, is recurrent, is multifocal, and is osteomyelitis. It is also known as chronic non-infectious osteitis. So naturally, it is non-infective. But to add to the confusion, to add to the challenge, to add to the problems, it need not be recurrent. So it can even be diagnosed in the first episode. It may not be multifocal. Clinically, if you see the patient, it may not be multifocal. So then how do we diagnose it? There are some sites which are characteristic. If you find a patient where the medial end of clavicle is involved or sternoclavicular joint is involved with inflammation or osteomyelitis, it is very characteristic of CRMO. So even the first presentation, isolated involvement of medial end of clavicle, you can think of CRMO. Similarly, involvement of bones of pelvis. So if there is osteomyelitis, inflammation of the bones of pelvis, we can think of CRMO. So these are some hallmark or characteristic sites. And we can also get what is done as whole body MRI, which is the investigation of choice. So if you have non-infective osteitis or inflammation of bone at one site, what we usually do or what should be done is whole body MRI to look at the clinical involvement of other parts of the skeletal system. If more than one part is involved, that is when you make the diagnosis of CRMO. And the treatment is with NSAIDs, glucocorticoids, even DMARDs like methotrexate, and bisphosphonates are also a treatment option for this. So we saw that some autoinflammatory syndromes can have fever as the predominant manifestation, like familial Mediterranean fever, which we don't often see. We discussed TRAPS. We discussed the cryopyrin-associated or NOMID. We discussed PFAPA, adenopathy, pharyngitis, and oral ulcers types. And we saw that all these patients presented with fever. So fever was the predominant manifestation. Then there are others in which musculoskeletal manifestations are also prominent. Again, like FMF, TRAPS, NOMID-like situations, CAPS. We saw BLAU, DIRA, CRMO, in which musculoskeletal manifestations are also prominent. So a group which has fever musculoskeletal manifestations. Then there are conditions in which CNS involvement is also seen, like the cryopyrin-associated NOMID, deficiency of ADA2, in which we saw stroke, and a group in which vascular involvement is also found, deficiency of ADA2, which can present just like childhood vasculitis or pan-like vasculitis. So if we try to group into these situations, it may become easy for us to identify these conditions. I would say that this is a large group of disorders, may not be easy to identify, may not be easy to pick up, but they must be included in our list of differential diagnosis, must be suspected in the correct context. And the correct context may be whenever you have unexplained manifestations or you have recurrent manifestations of fever, things like rash, arthritis. So if a patient continues to have fever, if a patient has recurrent episodes of fever, along with some manifestations like rash, arthritis, some manifestations we discussed like stroke, vasculitis, and these manifestations, if they remain unexplained, then autoinflammatory syndromes must be suspected. Some of them may not be as uncommon as we believe, like CRMO, PFAPA, but they must be looked for. We also understood that to diagnose autoinflammatory syndromes, we often need to exclude other conditions, including infections, autoimmunity, malignancy. And this all workup is usually done in these patients before we diagnose them to have autoinflammatory conditions. Family history, as I already discussed, many of these conditions are autosomal dominant in inheritance. Some are autosomal recessive. So family history sometimes helps, like we get a family member being affected in autosomal dominant conditions, a history of consanguinity in the family. It sometimes helps to make a diagnosis of these genetic disorders. Another important point that we all must know is that due to persistent inflammation, amyloidosis is a common complication in many of them. So I can recall a patient in whom we diagnosed an autoinflammatory condition as a workup of proteinuria. So the child was having massive proteinuria. When evaluated, found to have renal amyloidosis, and in retrospect, we diagnosed an autoinflammatory condition. So untreated autoinflammatory syndromes or persistent inflammation can result in amyloidosis as a complication of these situations. I would say that they are there. There is no reason for us not to have these conditions with us. But what is needed is that we must start looking for them. We must start including them in our list of differential diagnosis whenever we have the correct context. In the medical education, we are taught to think of common conditions. Yes, we must think of common conditions. Whenever we hear hoof beats, जब एक खुरों की हमको आवाज सुनाई दे, we must think of horses, but we must not forget zebras. So we must not forget the uncommon, unusual conditions like autoinflammatory conditions whenever we have patients with these manifestations. Now, with rare disease policy being in place, it has become a bit easier to diagnose these genetic disorders, these congenital disorders, to pick up these disorders. And once we start looking for them, I'm sure we'll be able to find out few cases of these conditions. And I hope that I was able to convince that these conditions do exist. And if we look at them carefully, if we look at the manifestations carefully, we may be able to pick up few of these autoinflammatory conditions. They may not be as uncommon as we believe. Thank you. Thank you so much.
Thank you, Dr. Avinash, for a wonderful presentation.
Can I stop sharing this?
Please stop sharing the screen. My request to Dr. S.P. Sethi, sir. For your comments, sir.
Thank you very much, Dr. Avinash Sharma, for the excellent presentation. You have managed to simplify a complex subject and given us practical takeaways for clinical practice. Hereditary periodic fever syndromes and autoinflammatory disease may be rare, but recognizing the patterns and knowing when to suspect them can make a real difference in a child's quality of life. I'm sure today's session will help many of us to approach these cases with more confidence. So I have simple one question, Dr. Avinash. In a resource-limited setting where genetic testing might not be readily available, what are the key clinical pointers or red flags that should prompt a pediatrician to suspect an autoinflammatory condition?
A nice question, sir. A practical problem. The point I would like to highlight is that we may not target to diagnose these conditions at our setups. The best way would be to suspect them. And as we discussed in these patients, if we remember those groups, like if a child comes to us with recurrent episodes of fever, he refuses to get well, whatever you do. Like if a child is having recurrent episode again and again having fever, that may be one of the most prominent manifestations of some of the autoinflammatory syndromes. So periodic fever, one group, may not be difficult. I think many of us would now start recognizing this. But the other red flags, as you say, may be presence of these sterile bone lesions, sometimes sterile skin lesions like pyoderma gangrenosum, pustulosis. So sterile lesions at places which are non-infective, which look like infective but are non-infective, may be a pointer towards the autoinflammatory syndromes. Then, as I said, recurrent stroke, vasculitis in children. So not all vasculitic disorders, but disorders like polyarthritis nodosa. If you are suspecting vasculitis in a child, that may be a situation where we can think of autoinflammatory syndromes. Now, I'm sure even genetic testing is available at many places. It is also being, I would say, used, abused, misused. So you may not like to do genetic testing upfront, but in the right context, the best way would be to send such patients, because they are rare. They may be seen by an expert who is well versed with these conditions. So our main aim would be to suspect these conditions. Then there are others who do not require genetic testing. Like I said, PFAPA you can diagnose clinically, again based on periodic fevers. Based on those lytic lesions, you can diagnose conditions like chronic recurrent multifocal osteomyelitis. So if you have a keen eye to look for these symptoms, we may be able to diagnose these conditions.
Thank you. Thank you very much.
Thank you, sir.
Dr. Sham?
Thank you, sir. First of all, as usual, I heard your previous session also very carefully. You nicely cover the whole things. Your all 7 cases are the unique, and very simply you conclude the such a versatile, very big topic. And after your 7 cases, you concluded in the last 2 slides. That is a very useful for our resident. How can we suspect such a rare thing in the simpler way by the history, by the classical presentation? Because in the opening you said the temperature recording is very informative. Don't take very lightly and don't hurry to start the antibiotic or anti-tubercular drug. Because in this disease, after heard your session or presentation, that the temperature recording is very important, because we daily seen in the our clinics, we are not very serious about the recording of the temperature and very hurry to do the non-relevant investigation and antibiotic. So that is very important thing. Other things is the ESR, because in the rheumatology, I heard the last 5-6 sessions, the ESR is very silent marker for the rheumatology diseases. So any child that have the documented fever with elevated ESR, with or without musculoskeletal or recess involvement, definitely that is enough give the clue to do the further relevant workup from the expert like the rheumatologist side. So thank you, sir. I just want to take from your side that you said the node mutation, tumor necrotic factor receptor mutation, because as a gastroenterologist, we are also facing that diseases, that child have the inflammatory bowel disease, Crohn's disease like
Yes.
that. So that mutation only isolated manifest like the hereditary fever syndrome or just maybe multisystemic?
Thank you, sir. Thank you for bringing this point. In fact, we have patients of autoinflammatory syndromes who present like inflammatory bowel disease. So infantile, I'm sure you are aware of the entity called infantile IBD. So
IBD.
infantile IBD is an autoinflammatory syndrome. NOD2 mutation is associated with ulcerative colitis. NOD2 has also been found to be associated with certain other GI abnormalities. Similarly, the TNF receptor mutations. So GI manifestations of autoinflammatory disorders is also a group which can be discussed separately. Inflammatory bowel disease, as such, can be grouped into autoinflammatory disorders. It has been seen that a part of inflammatory bowel disorders is autoimmune, and the other group of inflammatory bowel disease is autoinflammatory. That is, innate immune system is involved. So you rightly said that inflammatory bowel disease is a prominent manifestation, and these mutations, including NOD2 and TNF receptor mutations, are seen in patients of IBD as well. Yes, sir.
Thank you, sir.
Good morning. This is Dr. Anu. Can I ask Dr. Avinash sir a question?
Yeah, sure, ma'am. I am sure you must have seen many more patients than I have.
Dr. Avinash, an excellent presentation, a very simplified presentation. I think I was really very happy that you didn't go into complexities and made everything simple. Sir, I just want to ask you one thing. You said to do a targeted genetic testing. Uh, do you agree with this, or do you
Right.
think that with the commercial
No, no, no.
exomes that we are using, the cost between the targeted and the whole
Not
is
much.
just 2,000 rupees?
Yes.
So sometimes, these patients have very, very varied presentation, and you really don't know what's going to come. So would you recommend doing targeted or a whole
Right.
exome?
So if you see it carefully, or if you go through it carefully, I did not say that you should do a targeted sequencing. The point I wanted to highlight is that we did a targeted sequencing because these are the typical cases.
Okay,
Typical
okay.
case of Blau syndrome, you know that this is going to be Blau. So we
Yeah.
head for clinical sequencing. But in no way you can do a targeted sequencing in a condition, in a group of disorders which is as diverse as autoinflammatory syndromes. They can present, we know, they can present with anything. The case I
Absolutely.
presented are typical cases of
Typical
Norman,
cases.
typical case of Blau, where you can even clinically diagnose them. That is why I said that we did a targeted sequencing, and I must also reveal that these patients that I discussed, especially NOMID, was seen long back when I was doing DM, when doing a genetic testing was not that easy. We used to send the samples abroad with the diagnosis in clinical diagnosis in place. So now with, as you rightly said, now with genetic testing being available everywhere, it is better to do a whole exome sequencing. But again, I would highlight that the genetic testing is nowadays is being abused more than used,
Absolutely.
misused. So I would suggest not to go ahead with genetic testing before one has consulted an expert who has some expertise in these group of disorders. These are not common, so you may not find many of them in your clinical practice. So if you come across one, it is always better to discuss with someone who is an expert. You may not send the patient, but it is always better to discuss with someone who has some expertise in these group of disorders.
Yes, that's why we keep discussing all these cases with you,
Yes.
sir, with Dr.
Many,
Ankur,
many
with
times
Dr.
मैंने तो
Pratap,
देखी
everyone. And sir, one more a pointer, which there's been a recent amendment in the national policy of for rare diseases. In fact, now they have said that even they would be willing to foot the bill for the genetic testing also,
Yes,
as
yes,
long as they come through the COE. So I
yes.
think that's a big change that they have done, because most of the patients are poor and we keep getting stuck in the rut of infections only. And most of these children get ATT, which is very, very sad because genetic testing is widely available. And I think so are the pediatric rheumatologists. I think we are a growing field, we are a growing bunch, right? Dr. Ankur, would you like to say something? Dr. Pratap is also here. Dr. Ankur? I saw Dr. Yeah.
Yeah. I was actually in a conference, so
Oh, okay. No
getting
worries. I
the
thought you were
background
there.
disturbance. But no,
Okay.
it's very interesting presentation. No, I was listening. But I was just saying that there may be a little bit of background disturbance. So everything was so good, ma'am. I think Dr. Ma'am presented very well. I think the key message that he has rightly delivered is suspicion of these disorders. And we, of course, do not suggest these disorders are being managed by general pediatricians. I mean, these are complex diseases. So I think suspicion, screening them, and then obviously taking help from a pediatric rheumatologist or immunologist who is more versed with managing these disorders is something which is a key message that Dr. Avinash is trying to do. And I think this, when you mentioned about this policy, I think it's a big change which can help these patients.
Thanks, Dr. Ankur. Dr. Pratap sir, Dr. Pankaj sir, would you like to say something?
Yes, ma'am, that was an excellent presentation by Avinash Sharma sir. And just to add one thing, pediatrician must be diagnosing many cases of systemic GIA. And
Yes,
systemic GIA is now, it is grouped under autoinflammatory conditions.
absolutely.
And but diagnosing or before labeling somebody as systemic GIA, molecular testing should be also carried out.
Yes,
And so Dr. Avinash sir has rightly given message by many cases that any patient who is having fever, which is recurrent and periodic, associated with rash, associated with joint pain or CNS manifestations, one should suspect autoinflammatory conditions. Though these conditions are rare, they are not uncommon.
absolutely, Dr. Pratap. And most of these children do present as systemic onset JIA, and many years lapse between the diagnosis of SOGIA and the actual diagnosis.
Yes,
Isn't it? It's
yes,
not ki upfront ki the patient comes and you make a diagnosis of autoinflammatory. There is a period of a few years that go by before we kind of
yes,
start
ma'am.
thinking about
Yes.
it. Yeah.
Yeah.
Pankaj sir, Ajay sir, if there's not anything else.
Thank you, Dr. Anu, and thank you, Dr. Avinash sir and Dr. SP Sethi sir, and thank you, Dr. Shyam.
Thank you.
We are thankful to all the delegates for joining in early in the morning. Next week, we have a session on Kawasaki disease. So please join in time.
I
Thank
think
you
that's
so much.
going to be very interesting, sir.
Yeah.
Thank you.
Thank you,
Bye.
sir.
Thank you.
Thank you.
Bye.
Okay.
Bye.
Thank you. Thank you very
Thank
much.
you so much. Thank you.
Thank you. So,